It is my pleasure and honor to introduce our first speaker, Dr. Manal Salman, Professor of Pathology. She has a very wide, long experience in renal pathology, especially electron microscope. She will talk about pathology, renal pathology update. تفضل دكتور منال.
شكرا. السلام عليكم ورحمة الله. أنا بحب أشكر اسم النفرولوجي والدكتورة هويدا شناوي والأورجنايزنج كوميتي للدعوة الكريمة، وإن شاء الله يعني نعمل محاضرة في 30 دقيقة تبقى يعني سريعة كده إن شاء الله. هنتكلم عن kidney injury in systemic diseases pathology updates. We all know that renal affection may occur in the course of a huge number of systemic diseases. And this affection ranges from acute injury to chronic damaging injury. This may be glomerular, tubulointerstitial, vascular, or combined infection of different compartments. We will try to cover the pathological features of renal injury in some common and some important systemic diseases in this lecture. We are going to cover renal lesions occurring in some systemic immune-mediated diseases, some vascular diseases, some metabolic disease. We are going to cover diabetes, and dysproteinemias and paraproteinemia. Regarding diabetes mellitus, of course, we all know that diabetes can affect the kidney at the short-term and long-term effects. By increasing susceptibility to infection, of course, diabetes can increase the risk predisposition for pyelonephritis. By arteriosclerosis caused by diabetes mellitus, this will lead to ischemia, and combined effect of ischemia and pyelonephritis can lead to papillary necrosis. Arteriosclerosis together with hyperglycemia, the short term, will lead to hemodynamic circulation and hyperfiltration. And this hyperfiltration can lead to injury of podocytes and secondary focal segmental glomerulosclerosis. Hyperglycemia lasting for a long period over 15 years or more will lead to deposition of advanced glycosylation and the products in the kidney. This deposition in the mesangium and in the basement membrane will lead to the occurrence of what is called diabetic glomerulosclerosis, and this is characterized by nephrotic syndrome. The diabetic glomerulosclerosis, which is diabetic nephropathy, was classified by the Renal Pathology Society into 4 classes in 2010. Class 1, 2, 3, and 4, depending on just thickening of the membrane or mesangial expansion or formation of mesangial nodules, or from cases of advanced diabetic glomerulosclerosis with sclerosis of more than 50% of the glomeruli. We are going to cover 2 cases to identify these classes in our cases. The first case was a male patient, 71 years, with diabetes for 18 years, complicated by hypertension that is not complicated but controlled. By light microscope, there were 21 glomeruli. 12 of them showed just mesangial expansion like that with mesangial matrix and few mesangial cells. Mason trichrome highlights well the mesangial matrix expansion by this green color, but no nodules are seen yet. Two of the glomeruli showed formation of nodules, and so we started to have some nodules, and some of the glomeruli, about 38% of the glomeruli showed global glomerulosclerosis. There were mild IFTA and mild hyaline arteriolosclerosis. This case was signed as diffuse and nodular diabetic glomerulosclerosis, class 3, due to the presence of glomerulosclerosis global, less than 50% of the glomeruli. The other case was a male patient, 62-year-old, with type 2 diabetes for 15 years. He has uncontrolled hypertension, and so the glomeruli in this patient showed more and more nodular formation. We have more and more nodules, and we can see fibrous thickening of the Bowman's capsule and wrinkling, which is a sign of hypertension. We have more and more globally sclerosed glomeruli and more IFTA with more and more hypertensive changes in the glomeruli. The globally sclerosed glomeruli represented 60% of the total glomeruli, and the rest showed nodular and diffuse glomerulosclerosis with hyalinosis lesions and fibrous thickening of Bowman's capsule. Some of the glomeruli as well showed, this shows the diffuse mesangial expansion. This shows hyalinosis lesions. These are hyalinosis lesions. And here we have again the fibrous thickening of Bowman's capsule. This one shows hyalinosis lesions beside the mesangial nodules and hypertensive changes in the capsule. And this shows a diffuse mesangial expansion and areas of hyalinosis. By electron microscope, we see this is the basement membrane, which is thickened more than normal, about twice thickening of the normal, with areas of wrinkling. Other areas showed mesangial expansion with formation of mesangial nodules like that. And other areas showed well-defined high lienosis lesions that were seen in the light microscope. And this case was signed as advanced diffuse and nodular diabetic glomerulosclerosis with global glomerulosclerosis 60%, and this makes it class 4 with acute on top moderate EFTA and moderate hyaline vascular changes. This was for diabetes. Next, we are going to deal with vascular diseases, and vascular diseases, we are going to highlight changes in hypertension, TMA, and vasculitis. Hypertensive nephropathy or nephrosclerosis, we know that most of the renal diseases can cause hypertension, and at the same time, the sustained hypertension will damage the vasculature of the kidney. And this is particularly so in cases of accelerated or malignant hypertension. Early hypertensive nephropathy will cause mild albuminuria and decrease GFR. And hypertension will cause a pathology known as nephrosclerosis. This results from ischemia of the glomeruli and hyperfiltration leading to intraglomerular hypertension. In benign nephrosclerosis, we can see here two glomeruli, and these two glomeruli show ischemic collapsed simplified tuft with a very wide Bowman space and thickened Bowman's capsule and periglomerular fibrose. This one and this one. Two other glomeruli here are globally sclerosed, and we can see interstitial inflammation, interstitial fibrosis, and tubular atrophy, and some hyaline arteriolosclerosis affecting the afferent arterioles. In other field, we can see this is a collapsed glomerulus with starting focal segmental sclerosis at the perihilar region, and we can see globally sclerosed glomeruli, EFTA, inflammation, and hyaline changes in the vessels. More advanced cases seen here by Mason trichrome will show more and more of these green globally sclerosed glomeruli, and the rest will be the ischemic glomeruli. And we can see more and more EFTA and more vascular hypertensive changes affecting the medium-sized vessels and large vessels with fibroelastic hyperplasia. This occurs in benign nephrosclerosis. Malignant nephrosclerosis or accelerated phase of hypertension will have more profound effect on the vasculature. We can see here a small artery with fibrinoid necrosis affecting its wall. Another one shows mucoid intimal thickening with marked narrowing of the lumen. This glomerulus is normocellular with segmental capillary wall thickening. If we do Mason trichrome stain, we can see this artery and shows mucoid intimal thickening, segmental fibrinoid necrosis, and near obliteration of its lumen. And again, this glomerulus shows just segmental capillary wall thickening. Some arterioles here will show the hyperplastic arteriolosclerosis with near obliteration of their lumina. The glomerulus in this case showed what? Due to increased intraglomerular pressure, hypertension, this leads to rupture of the basement membrane with areas of fibrinoid necrosis and even areas of glomerular hemorrhage. This will lead to escape of RBCs into the renal tubules, leading to formation of red blood cell cast and hematuria. These are the features seen in accelerated phase of hypertension. The next one is thrombotic microangiopathy or hemolytic uremic syndrome. And this is a clinical syndrome comprising thrombosis in capillaries and arterioles throughout the body, together with microangiopathic hemolytic anemia with presence of peripheral schistocytes, thrombocytopenia, marked decrease in blood platelets, acute renal failure, and presence of platelet and fibrin thrombi in the interlobular renal arteries and glomeruli, together with necrosis and thickening of the vessel wall. TMA had a lot of different classifications before, and this was a classification assigned in 2018. It classified TMA into 4 main categories. The two upper categories are primary TMA, which may be hereditary due to mutation occurring in ADAM-TS13 gene in TTB, or in a complement gene mutation in atypical HUS. Or we have primary TMA acquired due to presence of autoantibodies to regulating factors for complement in atypical HUS or to ADAM-TS13 in TTB. We have the third category here is infection-associated TMA, and this is a very well-known case in childhood HUS, which is associated with Shiga toxin, E. coli infection, or some other infections can also be involved in this area. The last group is a heterogeneous group. This is a very large heterogeneous group of secondary TMA occurring in different conditions, as in together with pregnancy, glomerular lesions, malignancy, autoimmune diseases, severe hypertension, transplantation of bone marrow or solid organ, or drug-induced, as in cases of cyclosporine. In all of them, we have similar features in biopsy with very minor changes. The childhood HUS is characterized by diarrhea. It's caused by Shiga-like toxin secreted from E. coli, and we have severe oliguria, hematuria, and microangiopathic hemolytic anemia. In the kidney, we have fibrin-rich red cell-rich thrombi present in the glomeruli and some of the arterioles. It's usually confined to the kidney with absence of affection of different other organs, and usually it has a good prognosis. Adult TMA, HUS, and TTP, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura, it has a poorer prognosis than the classic HUS occurring in children with high mortality rate due to CNS disease or uncontrolled bleeding, and the survivors will develop chronic renal failure. The causes of adult TMA, we have very wide range of secondary causes of TMA. We have listed them before. And in TTP, which is the thrombotic thrombocytopenic purpura, usually it occurs in adults with predominant neurological manifestations, and the patient have abnormally low ADAM TS13 activity, either due to mutation or autoantibody. And it differs from the rest of cases of HUS and TMA by the presence of pale platelet-rich thrombi, not fibrin-rich thrombi. And these thrombi are present in myocardial arteries, pancreas, kidney, adrenal gland, or brain. The atypical HUS, atypical hemolytic uremic syndrome, is due to uncontrolled complement activation that results in complement-mediated TMA. And it differs from the classic HUS in absence of diarrhea and absence of Shiga-like exotoxin, but it has similar renal biopsy findings. It has frequent relapses even after complete recovery and can lead to permanent renal or neurological impairment. The causes of atypical HUS are genetic, acquired, or idiopathic. The genetic is due to mutation in one of 6 genes that control the complement pathway, and the acquired is due to autoantibodies to these factors. Regarding the pathological features in TMA in general, we have severely congested glomeruli. These are 2 glomeruli with severe congestion. We have a lot of hyaline fibrin thrombi in their capillary lumina. We have some fragmented RBCs present here in the mesangium. This was a case of HUS, and we have here a small solidified glomerulus. This is a very collapsed solidified glomerulus. There is merging between the mesangium and the capillary wall, and we have some fragmented RBCs in the background with no details in this glomerulus. This is a Mason trichrome stain showing this is the solidified glomerulus with some fragmented RBCs in this mesangium. And we can see here a small artery with mucoid intimal thickening of the intima, and there is marked narrowing of the lumen. This is another glomerulus from another case, and this case shows a severely congested glomerulus that is called paralyzed glomerulus. It shows paralysis. And this severe congestion is associated with the marked dilatation of the capillaries and marked decrease in the mesangium that is called mesangiolysis. And if we can see, this is the arteriole coming from this glomerulus. It shows some fibrinoid necrosis. This was another case, the glomerulus above. This is a semithin section stained with toluidine blue. And here we can see thickening and splitting of capillary walls here. And this glomerulus shows segmental fibrinoid necrosis, and this arteriole shows a luminal thrombus. This was another case. This case was characterized by presence of endocapillary hypercellularity and many neutrophils in the glomeruli. And some of the glomeruli showed areas of fibrinoid necrosis and occlusion of their arterioles by thrombi. And so we go to EM and see this case, and we found in this case a lot of subepithelial humps. You can see these subepithelial humps, and this case was assigned as post-infectious glomerulonephritis with secondary TMA. Regarding the EM features in all cases of HUS and EMA, we have the thickening and splitting of capillary wall here, seen in electron microscope as subendothelial widening. We have a very wide space between the basement membrane and the endothelial cell that is occupied by a flocculent, fluffy material containing some fibrin tectoids that are very dark and some of the platelet fragments. This is another photo showing this subendothelial widening by this flocculent material, including some platelet fragments and some fibrin. Regarding vasculitides, the primary systemic vasculitides may cause renal dysfunction through their ability to cause focal necrotizing glomerulonephritis. The vasculitides that affect the renal vasculature tend to be those that affect the medium-sized arteries beside the glomeruli. We have the ANCA-associated vasculitis, which is the granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, and we have the polyarthritis nodosa. The polyarthritis nodosa pan causes predominant arthritis, but without significant glomerulonephritis, but may manifest as glomerulosclerosis in hypertensive patients. While secondary systemic vasculitis can occur in the course of other diseases as systemic lupus, Henoch-Schönlein purpura, cryoglobulinemia, and so on. Regarding the ANCA-associated vasculitides, it is called ANCA-associated vasculitis or pussy immune crescentic. Why? Because it is characterized by a presence of segmental fibrinoid necrosis and crescent formation. This segmental fibrinoid necrosis is seen as area of fibrin on top of area of disruption of the membrane, and we can see here some infiltrating neutrophils. It is best highlighted in Mason trichrome stain, which appears very dark red in color. In the interstitium, we can vascular affection in the form of necrotizing vasculitis, and we can see this small medium-sized artery showing segmental area of fibrinoid necrosis infiltrated by inflammatory cells, and it is surrounded by inflammatory infiltrate. By immuno, it is negative, so it is called pussy immune crescentic glomerulonephritis. What is ANCA? To remind ourselves, ANCA is one of the antibody against neutrophils that is examined by indirect immunofluorescence microscopy on a serum, and it shows either C-ANCA, which is proteinase C-ANCA present in the cytoplasmic staining of neutrophils, or perinuclear ANCA staining, which is called myeloperoxidase or MPO ANCA, that stains the perinuclear area of the neutrophils. The ANCA-associated vasculitis is classified into 3 types according to the pathological features and the presence and the type of ANCA. We have the granulomatosis with polyangiitis, which was formerly known as Wegener, which has the upper and lower respiratory tract necrotizing granulomatous inflammation without asthma, and it is associated serologically with the C-ANCA, which is proteinase 3 ANCA. We have microscopic polyangiitis that has upper and lower respiratory tract vasculitic inflammation, but without granuloma or asthma, and is associated with MBO, B-ANCA positive. And we have the Church-Strauss syndrome, and this has eosinophil-rich granulomatous inflammation involving the respiratory tract with the presence of asthma, and like microscopic polyangiitis, it is associated with B-ANCA or myeloperoxidase ANCA. By light microscope, we can see here a glomerulus with necrotizing vasculitis affecting its arteriole in a case of microscopic polyangiitis. Here is another case of granulomatosis with polyangiitis showing fibrinoid necrosis of the wall with a cuff that forms a pseudogranuloma around this artery. And this is another case with fibrinoid necrosis and the granuloma containing giant cells and mononuclear cells in granulomatous with polyangiitis. If the granuloma is associated with many eosinophils like that, so the diagnosis will be Church-Strauss syndrome. All of kinds of these vasculitis will heal by fibrosis affecting the intima and media, and we have still a cuff of inflammatory cells around. By electron microscope, we have disruption of the basement membrane, areas of rupture, with fibrin exudation inside the capillary lumen and outside. This is the fibrinoid necrosis. The ANCA-associated vasculitis is classified according to ANCA specificity into proteinase 3 ANCA that is seen in GPA and MPO ANCA that's seen in microscopic polyangiitis and in Church-Strauss syndrome, and a small category is negative for ANCA. Histopathologic classification of ANCA-associated vasculitis was proposed by the European Vasculitic Group, which classified into focal crescentic mixed sclerotic according to the relative percentage of active sclerosing and active crescentic and chronic sclerosing lesions. The immune-mediated diseases, we are going to highlight lupus, Sjogren syndrome, cryoglobulinemia, and immunoglobulin G4 related disorders. Lupus nephritis, of course, has a classification that was proposed by the International Society of Nephrology, Renal Pathology Society in 2003, and it was revisited in 2016, and it classified the lupus into 6 classes. Class 1 was normal glomeruli, class 2 was mesangial proliferative, class 3 and 4 were the endocapillary or the proliferative lesions occurring in less than or more than 50% of the glomeruli, characterized by proliferation while loop thickening. We can have more and more active lesions in the form of cellular crescent, fibrocellular and fibrous crescents, and we can have fibrinoid necrosis occurring in these active proliferative classes. And we have class 5, which is the membranous with thickening, diffuse thickening of the membrane without profound endocapillary hypercellularity. If it occurs, so it can be combined with class 3 or class 4. And last, we have class 6, which is the advanced sclerosing of more than 90% of the glomeruli. By immunohistochemistry or immunofluorescence, we have granular fluorescence of capillary wall and mesangium for all types of immunoglobulins and all complement components. By electron microscope, we have mesangial electron deposits in all, we have subendothelial deposits in proliferative lesions, and we have predominant subepithelial deposits and intramembranous deposits in membranous lesions. Lupus nephritis was also, there was a modification in the NIH and activity score with the transfer of karyorexes with neutrophils instead of fibrinoid necrosis. Also, we talked about before about lupus podocytopathy, which is a unique subtype of lupus nephritis characterized by nephrotic syndrome. It manifests as minimal change disease or focal segmental with mesangial electron dense deposits, no peripheral electron dense deposits, and we have diffuse fusion of the food processes. And of course, it manifests clinically as nephrotic syndrome. Other lesions in systemic lupus include tubulointerstitial nephritis, which may be secondary to glomerular lesion or may be immune-mediated with the deposition of immune deposits at the wall of the tubules. We have interstitial inflammatory infiltrate, we have tubulitis, and then we have IFTA forward. Vascular lesion in the lupus, we have a variety of vascular lesion occurring in systemic lupus in the form of arteriosclerosis or immune deposit, here uncomplicated vascular immune deposit. We have necrosis of the vessels without inflammation, that is called lupus vasculopathy, or we have necrotizing vasculitis, fan-like in cases, and we have the TMA, thrombotic microangiopathy, seen in lupus, either with antiphospholipid or associated with HUS-TTB syndrome. Sjogren syndrome is a clinical syndrome with immune-mediated present in the salivary gland and lacrimal glands. We have affection of the renal lesion in less than 10% of the patient in the form of plasma cell-rich tubulointerstitial nephritis, and rarely we can have membranoproliferative cryoglobulinic glomerulonephritis. If you look at this picture, we have here interstitial inflammatory infiltrate rich in plasma cells, and we have IFTA because it is a chronic lesion, and this is a glomerulus showing membranoproliferative pattern and hyaline thrombi that occurs in cryoglobulinic glomerulonephritis. Immunoglobulin G4 related disorders is a component of systemic immune-mediated fibroinflammatory condition. It manifests in the kidney as acute or chronic tubulointerstitial nephritis with lymphoplasmacytic inflammation, but it differs from the previous that the plasma cells are positive for immunoglobulin G4 subtype. We have also tubulointerstitial immune complex deposition and storiform fibrosis with varying degrees of glomerular involvement, mainly in the form of membranous glomerulonephritis. This is a figure showing the dense inflammatory infiltrate that is rich in plasma cells with these cartwheel nuclei. And here we stain with PAS to highlight this storiform fibrosis. Of course, we cannot sign this unless we do immunohistochemistry to confirm the diagnosis. This is immunoglobulin G4 that stains the storiform fibrosis and many of these plasma cells infiltrating the lesion. Cryoglobulinemia is a systemic disease in which deposits for immunoglobulin G or M are seen together in the glomeruli, vessels, and synovium. It's called the cryo because it precipitates at 4 degrees and becomes soluble at 30. It's classified into 3 types, type 1, 2, and 3. Type 1 single monoclonal immunoglobulin seen in myeloma, Waldenstrom macroglobulinemia, and lymphoma. Type 2 mixture of 2 immunoglobulin, polyclonal IgG and monoclonal IgM. And type 3 polyclonal IgG and IgM. 2 and 3 are associated with B-cell lymphoma, chronic infection, chronic liver disease, lupus, and hepatitis C. And we have more common type 2 more than type 3. When we look at this picture, we have a membranoproliferative pattern with lobulation and hypercellularity, thickening and splitting of capillary wall. This is with an added presence of hyaline thrombi that are seen in H&E stain section, in Mason trichrome, and PAS stain section. If we go and do an electron microscope, we can see in some cases either confluent deposits or they have a substructure in the form of microtubules seen in the deposits. We need 5 minutes. 5 minutes. Last, we have dysproteinemia and paraproteinemia. We are going to talk about amyloidosis, immunoductoid, light chain disease, and of course, we talked about cryoglobulinemia. The myeloma, we have renal impairment is a common finding in cases of multiple myeloma, حوالي 20% من الحالات at presentation and 50% through the course of the disease. We have several factors that predispose myeloma patients to renal impairment, including cast nephropathy, amyloidosis, and light chain deposition disease. This is the cast nephropathy in which we have these distal nephrons showing dilatation, and they are filled with these brittle casts and surrounded by giant cells, and also we have injury of the epithelial cells and infiltration by inflammatory cell, tubular interstitial nephritis. Regarding light chain deposition disease, we have this pattern. This was a case, 56-year-old female patient. The glomeruli here showed mesangial nodules. You can see nodules in the mesangium, and we can see tubular and interstitial deposits that are PAS positive. When we do kappa and lambda, it was negative for kappa and positive for lambda, and this is present in only 20% of cases of light chain disease. And this lambda chain also stained the peripheral vessels. It was congruent negative. It was negative and not fibrillary in, by EM. So it was signed as light chain disease with lambda light chain restriction. We have amyloidosis, AL amyloidosis and heavy chain amyloidosis are related to plasma cell tumors, myeloma. And here we can see expansion of the mesangium by homogeneous pale eosinophilic material that is positive with Congo red and shows apple green birefringence under polarized light. By thioflavine, it shows positivity staining under fluorescent microscope, and by electron, it shows fibrillary appearance of randomly arranging fibers 10 to 12 nanometer in thickness. Immunoductoid glomerulonephritis is related to amyloidosis. It shows some mesangial expansion and capillary wall thickening, but it is Congo red negative. By electron microscope, it shows parallel microtubules ranging in size from 10 to 90 nanometer. Last one is also related to amyloidosis, fibrillary glomerulonephritis, that shows a thickening of the glomerulobasal membrane and mesangial expansion by homogeneous material that is Congo red negative. By electron microscope, it shows randomly arranging non-branching fibrils, solid fibrils that range in size from 12 to 14 nanometer. It overlaps a lot with amyloidosis, but it is Congo red negative. And alhamdulillah, fortunately, now we have a special stain, which is DNA-GB9, that's specific for fibrillary glomerulonephritis to confirm its diagnosis. In summary, we have renal involvement frequently occurring in course of wide range of systemic diseases, immune, vascular, metabolic, infection, and tumor. Pathologic lesions may be acute, leading to AKI, or may lead to CKD. Pathologic lesions may mimic primary renal diseases, and so exclusion of systemic diseases by clinical, serological, and pathological data is essential before considering a primary renal disease for proper management of the patients. And thank you very much.